Welcome, everyone. Thank you so much for joining us today. So this month's Fireside Chat is in honor of Colorectal Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement, as you can see here on the slide, we serve as a bridge between the Cancer Center and communities across the state of Minnesota. Our team's mission is to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. So my name is Amna Hussein. I am the Community Engagement Coordinator on our team. And on behalf of our team, thank you all so much for joining us today to help us raise awareness about colorectal cancer. Colorectal cancer remains the most preventable, yet is the least prevented cancer in our country. A concerning rise in colorectal cancer in younger people in recent years has prompted the federal task force to lower the initial colorectal cancer screening age and now recommend screening for colorectal cancer to begin at age 45 or even earlier for people with high-risk conditions. Okay, so today we are joined by Jecinta Scott, Medical Science Liaison at Exact Sciences for a discussion on colorectal cancer and an overview of colorectal cancer screening guidelines. It is my pleasure to introduce to you all Jecinta Scott. Jecinta has more than 14 years of experience in clinical and translational research focused on hematology and oncology at multi-regional health systems and academic medical centers across Kansas, Missouri, Minnesota, North Dakota, and South Dakota. In her current position at Exact Sciences, she supports healthcare providers by offering clinical and scientific information that helps guide medical decisions for cancer screening products as well as pipeline tests. In addition, she delivers clinical and scientific presentations to healthcare providers, health systems, and community groups on colorectal cancer screening and disease state. Prior to joining Exact Sciences, she was the Oncology Site Development Director at the University of Kansas Cancer Center, where she serves as the primary liaison between pharmaceutical sponsors and institutional providers. Prior to that, she was the Enterprise Director of Hematology and Oncology Research across the Stanford Health footprint. She holds a master's in biology and medical sciences and is currently pursuing a PhD in health sciences. We are so grateful to have her join us today. We will be recording today's session so that you can refer back to the recording, and we will post it on our YouTube page by the end of this week. We edit every recording before we post it to ensure your privacy. So if you're just joining us now, please take a moment to locate the chat and the mute buttons, because during today's presentation, please use the chat box to submit any comments or questions that you have, or you can even send them directly to me. During our discussion, following Jecinta's presentation, you will have the opportunity to unmute yourself and ask questions if you prefer. Again, it is my pleasure to introduce our speaker today, Jecinta Scott. Please take it away.
All right, first and foremost, it's most important that I unmute myself. Thank you. All right, can you hear me okay? All right, so I will go ahead and share my screen. So Amna, you should see my Zoom screen, and then I will start the presentation.
Actually, it looks like it's showing the Zoom launch meeting page.
Okay, and then let me know if you see my slide. Okay, perfect. So Amna, thank you so much for the warm introduction. I'm grateful to be here. We have such a great attendance, so thank you everyone. So overall, the focus of my discussion today will be on colorectal cancer as well as screening. And my goal today is to share some information about colorectal cancer screening to hopefully help you to start having the conversation about CRC, not only with your family members, but your doctors as well as your community. And really, we're hoping to help increase the rate of colorectal cancer screening, not only in the state of Minnesota, but nationwide. So this is our agenda. I will first begin by defining colorectal cancer. Then I will talk about some of the statistics that we're currently seeing with regards to colorectal cancer as well as screening. And then I'll talk about the risk factors, the signs as well as symptoms, and then talk about also the purpose of screening. So what are the goals of screening, as well as some of the new guideline recommendations. And then as Amna mentioned, the guidelines have decreased the screening rate for the screening age for colorectal cancer. So we'll talk about the current trends that we're seeing in those less than 50 years of age. All right, so let's begin by defining colorectal cancer. So overall, as a refresher, this is a basic anatomy of the colon and the rectum, which make up the large intestine. And the function of the large intestine really is to absorb just salts and water from food that has not been digested and get rid of that as a waste product. So the colon is a muscular tube, and as you can see, it's made up of 4 sections. So you have your ascending, your transverse, your descending colon, as well as your sigmoid colon. And then the rectum is just the final 6 inches of the large intestine. So I understand this slide may be more technical, and I realize we have a diverse audience here, but really the purpose of this slide is to show you how colorectal cancer develops. So colorectal cancer develops, as you can see, from a non-cancerous polyps or growth in the inner lining of the colon or rectum, and it can be further classified non-plastic, non-neoplastic. So these are the non-cancerous or benign lesions, or neoplastic, which are also called an adenoma or a precancerous lesion. So these are the lesions that have the potential of becoming a cancer. And in the next slide, I'll focus more on adenomas. So this is a picture of a cross-section showing the progression from an adenoma to a stage 4 cancer in the inner lining of the colon. And as you can see, about 70% of colorectal cancer develops from these adenomas. And what you're seeing here is that as it progresses from a stage 1 to a stage 2 cancer, it starts to grow deep into the walls of the colon. And at stage 3, which is the regional disease state, this is when it invades or spreads to nearby lymph nodes. And then at stage 4, which is the very last lesion you see there, so this is the distant or metastatic disease, and this is when the cancer progresses to distant organs such as the lung or the liver. And these lesions are very slow growing, and it typically takes over 10 years to develop from an adenoma to cancer, which again, it gives us a really good window of opportunity to try and identify and catch this disease early. So why do we care? So why is it important to screen? So as you can see on this pie chart, so this pie chart is showing the percentage of cases by stage. So in blue, what we're seeing is the localized disease. So this is the early stage 1 and 2. And then in orange is the regional disease. So this is stage 3. And then the distant or the metastatic disease. So that's the stage 4 in gray. And we know that early detection of colorectal cancer improves survival. And again, as Abna mentioned, colorectal cancer is the most preventable yet least prevented forms of cancer, with survivor stages that are significantly affected by the stage at diagnosis. So what that means is that about 91% of patients who are diagnosed in this stage 1 or 2, the localized disease stage, will survive for 5 years, but only 15% of patients that are diagnosed in this stage 4, that is the distant metastatic stage, will survive for 5 years. So it's really impactful when we think about it in terms of patients' lives. So next, I'll discuss, again, some of the statistics that we're currently seeing with regards to colorectal cancer. So these are estimates from the American Cancer Society. So there are CRC estimates for 2022. And of incidence, so the number of new cases as well as mortality. So the American Cancer Society is estimating over 150,000 new cases of colorectal cancer this year, which is making colorectal cancer the 4th most common cancer in the US. And ACS is estimating that there will also be over 52,000 men and women who will die from this cancer in 2022, making colorectal cancer the 2nd leading cause of cancer death in the US. And the overall lifetime risk of colorectal cancer, that is from birth to death, is about 4.2% in men and 4% in women. So that is 1 in 24 men and 1 in 25 women may have this disease in their lifetime. So this graph shows the incidence, so again, the number of new cases, as well as the mortality rates by race, ethnicity, and sex. And as we can see across the board, it is not spread equally. So African Americans, Native Americans, as well as Alaskan Natives have a higher incidence of colorectal cancer, as well as higher mortality. So more specifically for African Americans, the rates of colorectal cancer are 20% higher than what you see in their non-Hispanic white counterparts. And that number actually doubles when we look at mortality. So African Americans have about a 40% higher rate of death from colorectal cancer compared to their non-Hispanic white counterparts. And the reasons for these are very complex, but they're really primarily related to socioeconomic issues, as well as issues relating to access to care, as well as quality of care. So some of you on the call may be very familiar with the National Colorectal Cancer Roundtable, but for those who are not, the National Colorectal Cancer Roundtable was established by the American Cancer Society as well as the CDC, and really with the purpose to reduce the incidence of colorectal cancer as well as mortality. And the National Colorectal Cancer Roundtable is made up of public, private, volunteer organizations, and also individuals that are invited to join. And back in 2013, the NCCRT set a goal to reach an 80% screening rate in every community by 2018. And really not just by state, but every community in every state. And this is data that was collected in 2018 as a result of that campaign. And as you can see, we did not reach that goal nationwide. So the states in the dark blue, there were quite a number of communities that came close, a number of health systems and states that got close to reaching that. But overall, nationwide, we did not reach that 80% goal. So what you're seeing on the map is that the states in the dark blue were over 75%. In light blue were those states that made it to 70 to 75%. And as we go from orange to red, those numbers decrease. So again, we still have quite a lot of work to be done to reach that goal. And also, as is depicted here in orange, so orange is colorectal cancer, and then breast and pap tests are also depicted in the different colors. But as you can see, for colorectal cancer, in the early 2000s, the screening rates were just over 40%, and it continued to increase during that time. And at the 2018 rate, as I mentioned, we got really close. The screening rates increased significantly, but we did not again meet that National Colorectal Council roundtable 80% in every community. And also, as you can see, we're not quite yet at the screening rate for breast cancer or cervical cancer. So at the last data collection, we were at 67% in 2018, and meaning that 1 in 3 adults is not being screened as currently recommended by the guidelines. So this is data showing colorectal cancer screening rates by subpopulations, and these are for patients 50 years and older. So when we look at it by subpopulation and by age, what we're noticing is that the lowest screening rates are seen in those between the ages of 50 to 54. And by race and ethnicity, the lowest screening rates are in American Indians, Alaskan Natives, as well as Asians. And then for those that are college educated, their screening rate is about 80% compared to about 50% for those with less than a high school education. And then your status in the US also makes a difference. So patients that are born in the US have a higher screening rate compared to those that have lived in the US for less than 10 years. Those patients have just about a 28% screening rate. And then also insurance is a factor as well. So patients that have either Medicare or Medicare or both of those combined have a much higher screening rate compared to those that are uninsured. And the factors likely contributing to this low screening rates are primarily due to logistics such as transportation, scheduling, there are potential language barriers as well. Fear is also another barrier that's noted by patients, lack of knowledge, being low income or being underinsured, as well as just a lack of provider recommendation. So we know that the pandemic had a negative effect on screening rates, and data is coming out to support that as well. So this is data that was collected depicting the time period between January to July of 2020, and it's compared to the same time period in 2018 and 2019. And what you're seeing is that there was a significant decline in screening rates between March and June, and the lowest decline was seen in April. And even though screening rates improved back to almost to the rates that we were expecting, there remained about 3.8 million total estimated colorectal cancer screening deficits in the US in that time period. So there's quite a significant backlog of screening that needs to be made up. And when we think about the fact that we just the screening rate now includes those 45 to 50, and it's expected that it will add about potentially over 20 million new patients into the screening pool. Again, quite a number of patients that need to be screened, adding to this backlog as well. So with regards to the potential impact of the pandemic on future cancer outcomes. So the efforts to stop the spread of the virus, such as shutdown measures, social distancing, as well as just patients' fear of infection, and healthcare centers reallocating resources to more essential functions, really reduced access to care and led to a delay in routine care, such as preventative visits, symptom follow-up, and then follow-up from abnormal tests. So if a patient had a positive stool test, there were delays with regards to getting that follow-up or diagnostic colonoscopy. And then there were also delays with regards to patients being diagnosed. Patients were coming in with later stage disease. And by having that later stage disease, they probably have fewer treatment options. They may need more intense treatment, as well as just having lower probability of survival. And we also know that the pandemic caused a lot of delays with regards to just treatment and modifications in treatment. So patients coming in for cancer treatments were being surgery, radiation, as well as chemotherapy were being postponed. So next, I'll talk about some of the risk factors, the signs, as well as symptoms of colorectal cancer. So the term average risk is used instead of high risk because anyone with a colon is at risk of having colorectal cancer. And the concept of average risk versus high risk is really critical in terms of making decisions about screening. So a patient is considered to be in the average risk category if they're not in the high risk category. So by definition, an asymptomatic patients are generally considered to be average risk if they do not have a family history of colorectal cancer, an advanced precancerous lesion, inflammatory bowel disease such as Crohn's, and ulcerative colitis, a confirmed or suspected hereditary cancer syndrome, such as Lynch syndrome. And they're also average risk if they don't have a family history of a first degree relative. And by first degree relative, that's either a parent, a sibling, or a child who has had colorectal cancer or an advanced precancerous lesion, familial adenomatous polyposis, or hereditary non-polyposis syndrome. Again, those are big words, but obviously these are terms you can discuss to provider, essentially meaning that any of these hereditary syndrome, if patients has any of these personal or family history conditions, they are considered to be high risk. So these patients are not in the average risk screening pool. But there are also other factors such as lifestyle factors that increase the risk of colorectal cancer, such as cigarette smoking, diabetes, lack of physical activity, excess body weight, moderate to high consumption of alcohol, or long-term consumption of red or processed meats, as well as just consuming diets that are low in fiber, calcium, fruits, and vegetable. So one thing to note is that these factors may be considered when we're estimating if the patient's risk for average risk, but they alone do not elevate a patient beyond the average risk category. So having these lifestyle risk factors doesn't necessarily mean that a patient is considered to be high risk. So these are those same risk factors, but again, just broke it down into modifiable and non-modifiable. So the non-modifiable risk factors are those lifestyle risk factors which can decrease your risk of colorectal cancer. These are risk factors that we can actually essentially do something about. So these risk factors, while they do increase risk, patients are considered to still be at average risk. And the guidelines do recommend that these patients begin screening at between the age of 45 and 50. And for the non-modifiable risk factors, are factors that unfortunately we don't have any control over. So I'll point out diabetes as well as a patient's age. While these are non-modifiable risk factors, these patients having these risk factors is still considered to be average risk. But for those who are in the higher, where have those family history as well as a personal history of colorectal cancer or any of those inherited syndromes, those patients are in the high risk category, and the guidelines recommend that screening and surveillance begin at start at varying ages, and also these patients also have different intervals for screening as well. So the impact of these risk factors is shown on this table on the right. So as you can see, for those with a family history of colorectal cancer, those patients have between 1.7 to 4.0 times increase the risk of colorectal cancer compared to those who are not exposed to that risk factor. And it's about 1.7 times increase the risk for those with inflammatory bowel disease. And the risk is lower for patients with those modifiable risk factors. But it's also important to note that in the United States, about 55% of all colorectal cancer are attributed to those modifiable lifestyle risk factors. So again, as a community, as a patient, there's a lot that we can do when it comes to those lifestyle risk factors to decrease our risk of colorectal cancer. So someone can have cancer and not have any symptoms, which is why routine screening is so important. But a patient who presents with colorectal cancer may have signs or symptoms such as bleeding from the rectum, blood in their stool or in the toilet, dark or black stool. They may notice change in their bowel habit, or the shape of their stool might look a little different. They may have some cramping or pain in their lower abdomen. Constipation and diarrhea is also associated. And then they may have just decreased appetite, unintentional weight loss, as well as anemia and fatigue and shortness of breath. So these are signs and symptoms that you definitely should not ignore and really needs to be discussed with the provider, your healthcare provider, because as the tumor grows, it may lead to bleeding or block the intestine that can cause these symptoms. So next, we'll talk about the goals of screening. So why do we screen? So it's really important that as a community, we understand why screening is so essential. So the goals of screening are to detect disease in asymptomatic individuals versus individuals who have any of those precancerous lesions that are large enough to cause clinical symptoms or cancer. And it's also to detect and remove a precancerous growth. And the goals of screening are also to detect disease at an early stage when treatment is more successful. So again, these two points here are really critical, because not only do we want to detect and remove precancerous lesions early, but if we do screen routinely, we can find that disease early and at an early enough stage, like the stage 1, where the survival rates are a lot higher. And another goal of screening is to reduce colorectal cancer incidence as well as mortality. And we also want to screen to hopefully help increase survival as well. So these are the guidelines that recommend screening, and there are currently 5 major guidelines that are referenced in clinical practice. And those guidelines are the United States Preventative Services Task Force. We also have the American Cancer Society, the National Comprehensive Cancer Network, the American College of Gastroenterology, as well as the Multi-Society Task Force. And what you're seeing here in orange, so these guidelines do is the grade as well as the evidence that they have for the various screening age that they recommend. So they also recommend, so the guidelines also recommend not only the age for screening, but also how often patients should be screened and with which screening modality. So with regards to the age to begin screening, the guideline recommends screening should begin at the age of 45. And then screening should continue up to the age of 75. And then screening after the age of 75, what the guidelines are noting is that after the age of 75, screening should really be an individualized decision between that patient and their provider, really taking into consideration the patient's various comorbidities into consideration, and really assess if they're in a condition to be screened. So as I mentioned before, the guideline also recommend which screening modalities should be used for screening. And these are broken down here either into direct visual examination or stool-based test. So with regards to the direct visual exam, we have colonoscopy, which is recommended every 10 years. And as you can see, CT colonography, which is also known as visual colonoscopy, that is recommended every 5 years. Flexible sigmoidoscopy, that's recommended every 5 years as well. And then the guidelines are also recommending flexible sig every 10 years with an annual FIT test. And then for the stool-based test, they recommend the high-sensitive guaiac test annually. The FIT test is also recommended annually, and the multi-target stool DNA test or the Cologuard test is recommended annually as well. And it's really important to note that so all positive results on a non-colonoscopy screening test should be followed up with a timely colonoscopy. So again, any patient opting to do one of the other screening modalities, if they do outside of colonoscopy, if they do have a positive result, will have to undergo a colonoscopy as well. So just going into more details about some of the tests. So these are the screening methods that are, the screening methods here listed here are based on stool test. So these tests are non-invasive. They don't require any bowel cleansing or bowel preparation, and they can be performed at home. And with regards to their complexity, which is the time and effort and resources it takes to do the test, the complexity for these tests are low. And then their performance really relates to the sensitivity and specificity. So really, how well are these tests able to detect disease or rule out disease? So overall, the performance of these tests are intermediate. And then with regards to their limitations, these tests may have a positive result. So they maybe have a false positive result. And that essentially means that they may have a positive result, but have a negative finding on colonoscopy. And then unlike the Cologuard test and FIT test, the FOBIT test does also have some pre-dietary test restrictions as well. So next, we'll talk about the visual exams. So with regards to the visual exams, we do have colonoscopy. So colonoscopy examines your entire colon. It can biopsy as well as remove disease. So it's considered to be diagnostic and in some cases therapeutic as well. It's required for abnormal results from all other tests, as we mentioned, and it has the highest performance as well as the highest complexity as well to do the test. And then some of the limitations of colonoscopy is that it does require a full bowel cleansing. It is more expensive than some of the other tests mentioned. It does require a patient to be sedated, and also it may require patient to take time from work and have someone there with them to do the test and take them home after. And then it also has the highest risk of bowel tears as well as infection. And then CT colonography or visual colonoscopy examines the entire colon. It's fairly quick. It does have fewer complications. There's no sedation required. It's also considered to be a non-invasive. As far as its performance, it's high. And then complexity is that it's intermediate. It does require full bowel cleansing as well. And it cannot remove polyps or perform a biopsies as a colonoscopy would. And then exposure to low, can expose patient to low dose radiation. And if the patient does have a positive result on this test, they do need to have a colonoscopy as well. And then the flex sig is fairly quick. It does have fewer complications as well. There's minimal bowel prep that's required, and it does not require a sedation or it does not require any sedation. And then with regards to its performance, it's high for the rectum, and then also it also for the lower 1/3 of the colon. And then as far as its complexity, the complexity for the flexic is intermediate. And then some of the limitations of this test is that it does require a partial bowel cleansing. It views only 1/3 of the colon, so the lower 1/3 of the colon, and then it cannot remove large polyps. And then also there's a small risk of infection as well associated with this test. Colonoscopy is required if the test is positive, and its availability is also limited as well. So next, I wanted to talk about just conversation and dialogue as it relates to screening, as well as just a choice. So across the board, the Guideline organization recommends shared decision-making to improve screening adherence. And what shared decision-making means is when healthcare providers offer a patient a choice of test, and then they describe their risk and benefit, and then give the patient the opportunity to really express your preference and values, and then the decision is made based off of that. So the USPSTF, American Cancer Society, and NCCN have all released statements regarding clinicians and patients may consider a variety of choice between either a structural or stool-based test. And in terms of making a decision, so the choice of a particular test, the choice of particular screening modality should really include a conversation with the patient and concerning their preferences as well as the available resources that they have. And another point that AMNA made, which again, the American College of Gastrology has also noted, is that in some instances, the best screening test may be considered the test that a patient gets done, or the test that's acceptable to the patient. So next, we'll talk about some of those trends that we're seeing in those less than 50 years of age. I'll just take a sip of water. So why did the guideline organizations suddenly decide that 45 is the new 50? So as we can see on the top graph, so this is depicting those patients older, 50 years and older. So colorectal cancer incidence has gradually declined over the past 20 years in those older than 50. And that's been primarily due to screening as well as changes in exposures to risk factors. But when we look at the bottom graph, so this is looking at those between the ages of 20 to 49, there has been about a 51% increase in colorectal cancer incidence since 1994. And that is actually increased about 2% annually from 2012 to 2016. So again, the trends that we're noticing in this population is that increase in the incidence of colorectal cancer. And it's that steady, gradual increase, which is really alerting this guideline organization as far as some of the decisions behind decreasing the screening age. So these are the colorectal cancer 5-year survival as well as stage distributed by age. And really one of the key things that I wanted to note on here is that, you know, for those patients between 0 to 49 age group, they have a survival rate of 68% for all stages of colorectal cancer. But what I'll do is, so when you look at the graph to the right, so the 0 to 49 is noted in blue, and then 50 to 64, that's in orange, and then 65 plus is in gray, and then for all ages, that's depicted in yellow. But so when we look at that, a lot more of these younger patients are coming in with a stage 4 disease. So those between the ages of 0 to 49 have the highest proportion, so 26% diagnosed with that distant metastatic disease. And as we talked about previously, that distant metastatic disease, those patients have the lowest 5-year survival rate overall. So really, it's important to identify this age group and screen and catch this disease early. So as I stated previously, the lowest screening rates when we looked at the subpopulation was in those between the ages of 50 to 54 age group. And overall, this age group has a 48%, they're only about 48% up to date with screening. So one of the hopes in terms of decreasing the screening rate between to 45 is that by lowering the screening age, it's likely that it will have an impact on this 50 to 54 year age group. So these patients may come in and learn about colorectal cancer earlier and get screened earlier. So hopefully it's expected that by starting the discussion early, we'll catch some of the patient in this age group sooner than later. So in summary, colorectal cancer is the third most common cancer, and that is in men and women combined, and the second leading cause of cancer mortality. Early detection, as we know, improves survival, and approximately 70% of colorectal cancer, as we mentioned, develops from precancerous lesions, so these adenomas. And then colorectal cancer incidence is increasing, as we talked about, in the younger patient population, and it's expected to continue to increase. And for that reason, the guideline organizations have changed the screening rate and noted that screening should begin, the age of screening is now should start at the age of 45. So that is, I believe that's the last slide. So that should give us quite a number of time, hopefully, to start having to do the Q&A and discussion. All right.
Well, thank you so much, Jecinta, for your very informative presentation. I honestly learned a lot. So before we get started, I'm actually going to relaunch the attendance poll to capture anyone who came in after I launched the first one. And again, this is to capture attendance for the Amazon gift cards. Just give me a moment here. Let me launch the second poll. Okay. Do you see the poll, Jecinta?
I see it.
Well, people
Yes.
are clicking on it, so cool. So if you are dialing in and you did not have the opportunity to submit the first poll, please direct message me your name and email address so I can record your attendance, because that is the only way that you can receive your Amazon e-gift card. So I'll keep this open for just about a minute, and while everyone is doing that,
Okay.
I'm gonna get our fire going.
I like the idea of a fire.
Yes. Was missing in our previous Fireside Chats. Okay. Give about 10 seconds here. Okay, I'm going to go ahead and end the poll. All right, perfect. Okay, so we did have a few questions that came through, so I'm going to actually just ask those. Let me pull those up. Okay, Jecinta. So is there screening that is defective, that shows defective data from 2021?
So I haven't seen screening data for 2021 yet. So that's not information, unfortunately, that I have at the moment. But I think what we're expecting is to hopefully see how potential impacts of the pandemic in terms of overall screening. Yeah, so far, there was that one publication which I noted with regards to the impact that we saw for that time period between March and June of 2020, but I don't think I've seen data yet come out for 2021, at least not for the full year.
Okay, thank you. So then another question is, how does dairy decrease colorectal cancer risk? And has there been data on that?
Yeah, so one of the risk factors, one of the items that have been noted to decrease the risk of colorectal cancer is dairy consumption. I think it's noted as 400 grams per day. In terms of exactly how, that's not been noted, but there is some association with regards to that being a factor that decreases the risk of colorectal cancer.
Awesome. Okay. And then how many US people under the age of 50 years old are dying from colorectal cancer each year due to late detection?
So it's important to note that overall, the majority of colorectal cancer still is occurring in those over the age of between that screening rate of 50 to 65 and older. So the incidence of colorectal cancer in those less than 50 is actually about 10 to 12%. So majority of cases as far as incidence and death in terms of is still in that older population. It is quite less with regards to the exact number. I don't have that, but just keep in mind that the majority of cases as far as incidence and mortality is still in that older population. What is concerning is just the trend that we're seeing in the younger patient population. So having that consistent increasing trend is what's really most alarming to the guideline organizations.
Okay, so what can you say to a doctor who doesn't feel that you warrant an insurance coverage for a colonoscopy due to age, even when you have a family history of risk factors?
Oh, wow, that's a challenging one. You know, I think just starting to understand their reason or rationale. Another option could be maybe just, and some providers are open to this, maybe getting a second opinion, but I think it would be really important to understand why why they have that concern or why they would note that. But again, I think that would be the main thing. But then again, just maybe having the discussion with the provider or even getting a second opinion.
Okay. Thank you. So let's see, if you're unaware of family history, like in the case of adoption, do you fall into the normal category for screening?
Yeah, that's a really good question and one that's been brought up before. So if you're unaware of family history, don't know your family history. A lot of what I've heard in terms of what providers have noted is that those patients would still consider to be average risk, obviously, unless something changes that you become aware of.
Okay. So based on the slides, you stated that the recommended age for high risk, primarily family member with colorectal cancer, for example, depended on the patient. Do we just have the discussion with our primary care physician, or are there other resources for us to find out what that age would be?
Yeah, so there are quite a number of resources out there. Definitely check out the American Cancer Society website. The National Comprehensive Cancer Network just launched a patient screening guidebook that is available on your website. So again, there are quite a number of resources out there, but you definitely want to check out more of those accredited websites such as ACS, the CDC, the National Comprehensive Cancer Network. But overall, in general, when patients with a high risk or those with family history of colorectal cancer are recommended to begin screening early, such as by the age of 40 or 10 years before the earliest diagnosis of colorectal cancer. But yes, there's quite a number of resources out there to look at that yourself, or definitely if you find out that information, still talk to your provider.
Okay. So does having constipation increase your risk for colorectal cancer? Would this increase the odds of cancer or more easily develop polyps?
So having constipation is not noted as a risk factor, but if we go back and look at some of those signs and symptoms of colorectal cancer, it is noticed as a sign or symptom. But again, it's important to know that that may not be the only reason for it. So if you're having a constipation or chronic constipation, definitely talk to your provider. But it's currently constipation is not noted as a risk for colorectal cancer, but it is noted as one of the signs and symptoms. So if that's something that you're experiencing, please definitely talk to your provider so they can determine what could be the potential cause.
Thank you. And so along the lines of symptoms, I know that a lot of times with, experiencing chronic red blood bleeding, it could be attributed to hemorrhoids. So what do you typically suggest that patients who experience hemorrhoids should do?
Yeah, so there may be multiple or differential diagnosis in terms of just chronic bleeding, but certainly, again, as I mentioned, you want to confirm with your provider if hemorrhoids are the cause of bleeding or another source. But this question sometimes comes up because the FIT test is designed to detect blood from the lower GI tract. But but the data that's out there with regards to the prevalence of hemorrhoid is that hemorrhoids is about 39% of the general population have hemorrhoids. But in the large FIT studies that have been done, they consistently only showed lower GI bleed in about 77%, of the population. So this just suggests that majority of hemorrhoids are not associated with a lower GI bleeding. So if you do have that lower GI bleed, it's more likely that it can be due to, it can be caused by potentially associated with having a cancer rather than a non-cancerous source. So again, hemorrhoids are not necessarily always the cause of a lower GI bleed. It could be that it's a potentially cancerous.
All right, so this is actually news to me as well. So is there information available regarding the rate of tears due to having a colonoscopy? In other words, how common are the tears and typically what's done?
Oh, that's a really good question. And there is information available. So one of the clinical outcomes that the guideline organizations look at when they're assessing is really harms due to colonoscopy. So I will look at that exact number. I'm not in follow-up with you, but I think I'm pretty sure there's information available with regards to adverse events or adverse events as an association of colonoscopy.
Perfect, thank you. Okay, so there's a few questions that came in through the registration that I'd like to ask as well.
Okay.
So I know that you noted, that we're aware that there is an increase in colorectal cancer in younger adults under the recommended screening age, particularly highest amongst African Americans. So what do you typically suggest that young Black adults should do to lower their risks? And then also, do you anticipate that the screening guidelines potentially, it's a two-part question, could change again soon?
Yeah, so I like to think of this in terms of your modifiable and non-modifiable risk factors, right? So for your modifiable lifestyle risk factors, so it's definitely recommended to consume less alcohol, stop smoking, or just or don't even start it out. So quit smoking, don't start smoking. Being more active, definitely consuming diets that are high in calcium or fiber and less processed meats. And then when we think about those non-modifiable risk factors, so these are the risk factors that you have no control over. One of the most important things you can do with regards to those is really understand your family history. So when you start having that conversation and understanding your family history, that is information that can really help your healthcare provider in determining if you need to be screened sooner, or if you need to be screened sooner, and also just to determine overall, how prevalent is this disease in your family. So again, for the non-modifiable risk factors, understanding your history, and also that can also help your provider determine if this is something that's hereditary, which really also changes your how soon you need to be screened and how frequently. And then the second part of your question, I'm sorry. So do you, I believe you said you anticipate guidelines changing. So the American Cancer Society, their last update was 2018. And then the other guidelines, USPSTF and CN, they just updated their guidelines in 2021. So probably not for a few years, obviously, unless we start seeing a significantly different trend with regards to incidence and mortality. But most of the guidelines just updated in 2021. ACS was 2018, so it may not be a while till we see any changes to the guidelines.
Perfect. And so, I mean, along the lines of just family history and the role that genetics play. So what is the role of genetic testing if there is a strong family history? Is it important or necessary? And how do genetic results affect screening guidelines for an individual?
Okay. So with regards to that, I will say it's really important, especially for people with a family history of a family history of cancer or multiple cancers. So you definitely want to understand your family history. And one of the reason is that it's a tool, right? It's a tool that your healthcare providers can help other members of your family. So if you understand if there's an association between with family history and just genetic predisposition to cancer, they can use that. Having genetic testing providers can use that as a tool to determine how does this affect other members of the family. So it can help catch the disease early. So it's definitely something that you want to talk to your provider about if you're concerned about having family history and if you need to do any genetic testing to see if other members of if that's something that may also be with the other members of your family. And then for those patients who are high risk, including those with hereditary cancer syndromes, the guidelines recommend screening begins sooner. So screening may need to be done more frequently and with colonoscopy because these patients will fall into the high risk category. And screening may need to be initiated so earlier. So some guidelines recommend at the age of 40 or 10 years prior to when the youngest relative was diagnosed with cancer. So yeah, so genetic testing is important, and also understanding family history as an association to that.
Definitely. Okay. So I know you touched on this a little bit, but do you have any tips on just advocating for yourself when it comes to your provider not deeming that based on your family history, that a colonoscopy or just colorectal cancer screening in general is unnecessary for you?
Yeah, so again, as I mentioned before, I think one of the most important thing would be to understand why, and also potentially further exploring that reason. And I think most providers are open to you getting a second opinion. So definitely something that you can discuss with your provider or try and understand from another provider what you could be doing as far as getting that testing done. But I think most importantly is understanding why and then exploring that further.
Thank you. Okay, so I want to open it up again to all of our attendees live. If anyone wants to unmute themselves and ask questions, please feel free to do that or continue to submit them through the chat. So have some more questions here, but can you tell us some healthy foods and some options that you would recommend to help prevent colorectal cancer?
Yeah, so that's a good question. So unfortunately, there's still research that needs to be done to determine exactly what type of food. So I don't have any recommendations for exactly what type of foods, but as we talked about, so eating foods that are high in vegetable, calcium, and fiber, that's really important. Also, eating less processed or red meats, that's also really important. And one other thing that I don't think I mentioned this, so I know we enjoy our barbecues and grilling, but again, understanding that when we heat up food at a certain level, it may that charness or that burn can expose us to carcinogens. So really scaling down on some of those things can really help reduce those lifestyle associated risk factors.
Definitely. One of our researchers, Dr. Rob Tereski, actually does a lot of research in just well done meats and the impacts of that on cancer. So look into his work. I would highly recommend it. Okay, so let's see some other questions here. I think it looks like we've covered all the questions that came in through the registration.
Okay.
And I didn't see, are there any other questions that anyone would like to ask? Because this is your opportunity to do that.
Hi, I have a question. This is Bruce Forsyth.
Yes.
Just
can you actually speak up a little bit? I'm having a hard time hearing you.
Apologies. Yeah, so Dr. Scott, you work for Exact Sciences, right?
Correct.
Can you talk a little bit about diagnostic tests coming down the pipeline, maybe beyond colorectal, just in the minute or two we have left? I'm just fascinated by your kind of business and where you want to take it.
Yes, you mean for Exact Sciences in particular, I assume?
From your point of view, correct. Yep.
Yeah, so what we have at Exact Sciences in terms of colorectal cancer, obviously we have the Cologuard test, and there's current research in the works just in terms of how we can help improve that test in terms of sensitivity and specificity. So looking at the next generation Cologuard, and then we also are working on, as I think a lot of others in the industry are on a potential blood test as well. So that's also, again, industry-wide, what is in the pipeline. So that's for colorectal cancer. As far as other things that we have in our pipeline, we did also launch our OncoGuard liver, which is also a liver, a non-invasive test for detecting HCC. So that's another pipeline compound diagnostic test that we have. And there are one other or two other things in the pipeline, which unfortunately I'm not able to discuss at the moment. But as soon as that information becomes available, I'd be happy to share with you.
Thank you.
All right, are there any other questions for Jecinta? If not, I think we'll just wrap up a little bit early today. So Jecinta, thank you so much for taking the time to join us today and for this engaging discussion. Again, you will receive an email shortly following today's session with a link to complete a quick survey. So please do that. We would really appreciate your thoughts and feedback about this session because it will help us shape future Fireside Chats. And after completing the survey, you can enter to win a swag bag filled with Masonic Cancer Center goodies. So the $5 Amazon e-gift cards will be emailed by the end of this week to all who marked their attendance today. If you didn't, please direct message me your name and email address. And then also please follow the Masonic Cancer Center on all our social media platforms to stay up to date on our future announcements, as well as events from the Office of Community Outreach and Engagement. Again, thank you everyone so much for joining us. I hope you all have a wonderful day.
Thank you, Emma. Thanks everyone.
Thank you, Jecinta. Bye now.
Bye.